Begin our discussion with gastrointestinal regulatory substances. So first let us start with the G cells. G cells are produced, you can see, in the antrum of the stomach. They may also be sometimes produced in the duodenum, but mostly in the antrum of the stomach. They increase the hydrogen secretion in the actually body of the stomach, but they are present in the antrum. So how that is happening, you can see the G cells will activate the gastrin, and this gastrin will activate the ECL cells, and this ECL cells in turn will form a histamine, and this histamine will act on the parietal cells which are present in body of stomach, and that will lead to release of HCl. So this is how acid is produced in the stomach when G cells in the antrum are getting activated. And also this will lead to increase in growth of gastric mucosa and also increase gastrin motility. And one more thing, this gastrin can also sometimes directly act on the parietal cell and lead to release of HCl, or else it can go by this ECL cell pathway, histamine, like this. So two pathways you can see here clearly. Okay, and this gastrin is very important for H plus secretion mainly, and also for growth of gastric mucosa. So how it is regulated, whenever there is increase by stomach distension, whenever there is more distension of the stomach, or whenever there is alkalization. Why there will be more distension of stomach is when you eat more food, your stomach will get distended, so this G cells will activate it and they'll try to release acid for their digestion. And also whenever there's alkalization, that is because of more alkaline, so now they try to release H plus. And when are there more amino acids, peptides, and vagal stimulation via gastrin releasing peptide, actually vagus by GRP, you can see here, this is the vagus. Now by GRP it will activate the G cells, so that will also release. And whenever there is pH dropped, that is less than 1.5, pH is less than 1.5, then also this will get activated. Note that it increased by chronic PPI use. So when I use proton pump inhibitors, you are trying to decrease the acid, right? So at that time also this secretion will increase. And also in chronic atrophic gastritis, because of H pylori, when there is atrophy of gastrin, then also this gastrin will release more. And in Zollinger-Ellison syndrome, you know that there is a gastrinoma, so which is producing more G cells. For that we will do secretin test. Actually you can see here, for gastrinoma we'll do secretin test, and this gastrinoma may be present also in duodenum and pancreas. It may form an ulcer which is in the distal duodenum, and it may cause diarrhea, abdominal pain. Treatment is PPI, octreotide, and also surgery. Next, coming to somatostatin. So here you can see somatostatin, which is produced actually from the D cells of pancreatic islets and also GI mucosa. So actually somatostatin drops all the hormones levels, so it is released only when there is you know acid in stomach. When there is acid in stomach, only at that time somatostatin will be high, so that it can inhibit all the hormones. But when there is food, then the somatostatin will inhibit it, because all this hormone should work when there is food, right? So that is important. Somatostatin from the D cells, they decrease the gastric acid and pepsinogen secretion. They also decrease the pancreatic and small intestine fluid secretion. They decrease gallbladder contraction. They also decrease insulin and glucagon release. So mainly they are activated whenever there is more acid, and whenever the vagal stimulation has stopped, in that time this will get activated. And they mainly inhibit the secretion of various hormones. And octreotide is an analog for this, that is used to treat acromegaly, carcinoid syndrome, VIPoma, gastrinoma, glucagonoma, all these things. Next, coming to cholecystokinin, which is released from eye cells. You can see clearly it is in the duodenum and also in the jejunum. Actually they increase the pancreatic secretion, and also they increase the gallbladder contraction. In the name itself you can see cholecystokinin means it is increasing the contraction of gallbladder and decrease the gastric emptying. Why they decrease the gastric emptying? So that these pancreatic enzymes can act on it. Okay, and also it increases sphincter body relaxation, so that more enzymes from the pancreas and gallbladder can act on the food on small intestine. And one more thing, they are activated whenever you eat more fatty acids and more amino acids, because it is the site in the intestine where this enzymes will come and act. And next they act on mainly neuromuscular pathway to cause pancreatic secretion, that is by acetylcholine stimulation. They will lead to stimulate more amount of pancreatic secretion. And we do hida scan to find out the CCK. Next, coming to secretin is released from the S cells, you can see clearly in the duodenum. They increase the pancreatic bicarbonate by pancreatic duct cells, and they decrease the gastric acid secretion because it's bicarbonate, right? So it will dissolve the acid condition and increase bile secretion. So this is also increased when you eat more fatty, when there are more fatty acids in human, so that they'll decrease the acid, and increase bicarbonate so that it will neutralize the gastric acid in duodenum, allow pancreatic enzyme to function. So whenever the secretin is there, all the pancreatic enzymes can work because it creates a bicarbonate alkaline medium here in the intestine. Next, coming to glucose dependent insulinotropic peptide, which is released from K cells, okay, GIP. In short form, you can call GIP. It is also secreted from both duodenum and jejunum. Actually, it's exocrine. They decrease the hydrogen secretion, gastric hydrogen secretion, and also endocrine function is increase insulin release. So it is having exocrine and endocrine. Endocrine function increase insulin release. Exocrine function decrease hydrogen secretion. So this is also activated when there are more fatty acids, amino acids in the intestine. Next, they are also called gastric inhibitory peptide. And oral glucose load increase insulin compared to IV equivalent due to GIP secretion. Actually, oral glucose load will increase the insulin compared to IV because of equivalent to GIP secretion. Next, coming to motilin. Motilin actually is produced in small intestine. It produces migratory motor complexes which are mainly increased in fasting state. So whenever in a fasting state, our body will get actually wash out because of increase in motilin. So motilin receptor agonists are like erythromycin. They are used to stimulate intestinal peristalsis. So erythromycin can be used as treatment in the case of gastroparesis when we want to clean the intestine because it will initiate the intestinal peristalsis. Next, coming to vasoactive intestinal polypeptide, it is a neurocrine function. It is source is from parasympathetic ganglia in the sphincters, gallbladder, and small intestine. Its function is to increase water and electrolyte secretion. That is nothing but increasing the pH, right? And increase relaxation of intestinal smooth muscle and sphincters. So actually it is activated whenever there is increased distension by vagal stimulation and decrease by adrenergic input. So in this cases, this will get activated. VIPoma is non-alpha, non-beta islet cell pancreatic tumor that mainly secretes VIP, and it is associated with watery diarrhea, that is a tea-colored diarrhea, and hypokalemia it causes, and also cause echlorrhea. So this is WDHA syndrome. There is pancreatic cholera syndrome, also called pancreatic cholera syndrome. Increase VIP in the serum, and treatment for VIPoma is octreotide because it is a somatostatin analog. It inhibits all this function. Next, coming to nitric oxide. Nitric oxide action is to increase smooth muscle relaxation, including lower esophageal sphincter. So the notes is like its loss of nitric oxide secretion is implicated in increased lower esophageal tone of eclasia. Next, ghrelin. Ghrelin is from the stomach. It increases the appetite. It is increased in fasting state and decrease when you are eating food. And it is increased in especially Prader-Willi syndrome, and also it decrease after gastric bypass surgery. Now let us discuss the gastrointestinal secretory products. First one is the parietal cells. You know that parietal cells produce the gastric acid, and they can also produce the intrinsic factor. You can see this is the HCl, this is the intrinsic factor. So the gastric acid from the parietal cells, they try to decrease the stomach pH, and they're regulated by both histamine and vagal stimulation. They both can rise the acid secretion. Next, coming to intrinsic factor, it is also coming from parietal cell. It is having B12 binding protein. It is actually vitamin B12 binding protein, which is required for B12 uptake, especially in terminal ileum. So actually, this is decreased. This intrinsic factor can be decreased by somatostatin, GIP, prostaglandin secreting. All those can decrease the intrinsic factor. Actually, they decrease the intrinsic factor by cyclic AMP, GS, GI system. they decrease the hydrogen in the lumen. So by that mechanism they act, and autoimmune destruction of the parietal cells can cause chronic gastritis and also can cause pernicious anemia. Next, coming to pepsin. Pepsin is released from the chief cells of the stomach. They are useful for protein digestion. They are activated by vagal stimulation and also acetylcholine local acid. So pepsinogen is actually inactive form. It is converted into active form by the presence of hydrogen ion. Next, coming to bicarbonate. Mucous cells actually produce a mucus that is nothing but the bicarbonate. Okay, and they are also present in stomach, duodenum, salivary glands, pancreas, Brunner's gland, and duodenum. They actually neutralize the acid. So you can see till here acid is present, but here they're trying to neutralize the acid. This is increased by pancreatic and also biliary secretion with secretin. They're trapped in mucus, covers the gastric epithelium. One thing is that you may understand, like, lot of acid is producing, then how stomach is protecting itself from acid? By this mucus bicarbonate only, which is secreted mainly from the neck cells. Okay, and actually omeprazole, pantoprazole are the drugs which block the acid secretion, right? And this H plus, which is formed mainly by carbonic anhydrase, also forms alkaline tide after the meals. So after the meals, if you check out your serum, then you will see more bicarbonate in the serum, because more hydrogen is secreting here into the stomach and more bicarbonate is going into the serum in your blood. So the bicarbonate will be rising. That is called alkaline tide after the meals. And one more thing, vomiting. When you vomit out the contents from your stomach, especially the HCl will drop in your body, and that will lead to metabolic alkalosis. And urinary chlorine will also drop, will be less than 20. If the urinary chlorine is greater than 20 after vomiting, then you should think it is because of diuretic use. And acetylcholine and gastrin are mainly acting to GQIP3 calcium pathway, and they increase the hydrogen ion in the lumen. Whereas somatostatin, prostaglandin, all those act by cyclic AMP GSGI, and they try to decrease the hydrogen ion in the lumen. One more thing in pernicious anemia is that there is loss of parietal cells. So because of that, it can't absorb B12, and that will lead to rise in gastrin. Why gastrin is rising? Because our body thinks to activate the gastrin so that it can produce intrinsic factor, but there is no, actually there's a problem in a parietal cell. So even the gastric is increased, the G cell will undergo hyperplasia, but there will be no formation of intrinsic factor, and that will lead to pernicious anemia. Now once let us see the locations of different substances which are releasing from the stomach. So from the antrum you'll get the gastrin, and CCK, secretin, and GIP are coming from the duodenum and jejunum. You can see secretin, CCK, GIP, and motilin, VIP, somatostatin are coming from antrum, duodenum, jejunum, ileum. So motilin, somatostatin, and VIP are coming from all antrum, duodenum, jejunum, and ileum. Now let us check out the pancreatic secretions. Actually, pancreatic secretion is isotonic fluid. So whenever there is low flow in the pancreatic secretion, there will be high chlorine but low bicarbonate. When there is high flow, there will be high bicarbonate and low chlorine. So secretin actually stimulates for bicarbonate release by S cells, and ductal cells, they modify the bicarbonate. So there are different enzymes released here in the secretions of pancreas. Alpha amylase, which is for starch digestion, mainly by breaking down alpha 1,4 linkage. They're secreted in active form, and they're increased especially in acute pancreatitis. The brush product contains oligosaccharide hydrolysis. Next, lipases are for fat digestion. They are having a co-lipases, phospholipase A2. They're like co-lipases and phospholipase A2. Both of them are used for fat digestion. Next, proteases for protein digestion. They include trypsin, chymotrypsin, elastase, carboxypeptidase. They are actually secreted as proenzymes, also called zymogens. Next, trypsinogen is converted to active enzyme trypsin by activation of other proenzymes and cleaving of additional trypsinogen molecules to active trypsin. That is a positive feedback loop. So it is converted to trypsin by enterokinase or entropeptidase, a brush border enzyme on duodenum and jejunal mucosa. So the dipeptides and tripeptides are degraded within the intestinal mucosa. So now here you can see the carbohydrate absorption. Actually, SGLT1 is useful to absorb the glucose and galactose along with sodium, whereas GLUT5 is used for facilitated transport of fructose from the apical membrane. This is enterocytes. So from here the nutrients whichever you are eating are going like this, and They are going by means of GLUT2 into blood. How to remember this? For example, now you have eaten rice. Rice is carbohydrate, so that rice, in that the glucose and galactose along with the sodium are transported by means of SGLT1 into your intestine, enterocyte, and next by GLUT5 fructose goes. So like this, finally they'll go to GLUT2, and from GLUT2 to basolateral membrane to the blood vessel. We do the D-xylose test. Actually it's a simple sugar test we do, where sugar should normally get absorbed, but if it is not getting absorbed, then you can say there's some mucosal problem. There's mucosal damage. And actually remember, in pancreatic insufficiency there's no problem with this, so D-xylose test will be positive in pancreatic insufficiency. So cholecystokinin is the main stimulus for pancreatic enzyme release by acetylcholine, that is called as vasovagal reflex. In acute pancreatitis, there will be more amylase and lipase, but lipase is more specific for acute pancreatitis. And in acute pancreatitis, there is autodigestion of pancreas, and we can do enzyme replacement for cystic fibrosis, chronic pancreatitis, and post pancreaticectomy, because here the pancreatic enzymes are lost, so we do enzyme replacement. Next, coming to vitamin and mineral absorption. For this, you can remember the mnemonic iron first bro. Iron means iron is absorbed as Fe plus 2, especially in your duodenum, and folate is absorbed in your small bowel, and vitamin B12 is absorbed in the terminal ileum with the help of intrinsic factor. So that is the reason why vitamin and mineral deficiencies may develop in patients with small bowel disease, bowel resection, or bariatric surgery, which is done for obesity patients, right? Example, vitamin B12 deficiency after terminal ileum resection, because iron, folate, vitamin B12 all are absorbed, especially in a small intestine, right? Now let us move on to Peyer's patches. You can see this one. This is a Peyer's patch, which is unencapsulated lymphoid tissue found in lamina propria and also in the submucosa of ileum. It contains specialized microfold M cells that sample and present antigens to immune cells. So B cells are stimulated in germinal centers of the Peyer patches. They differentiate into IgA secreting plasma cells, which ultimately reside in lamina propria. So IgA receives protective secretory component and is then transported across epithelium to gut to deal with intraluminal antigen. So always think of IgA, the intragut antibody, which is present especially in Peyer patch in your terminal ileum. Now let us continue with bile salts. So bile salts are actually bile is composed of actually bile salts, and bile acids are conjugated to glycine or taurine, making them water soluble. So bile salts are actually not water soluble. As they are conjugated with glycine and taurine, they are becoming water soluble. Phospholipids, cholesterol, bilirubin, water, and ions all are present in the bile. Cholesterol 7 alpha hydroxylase catalyzes the rate limiting step of bile acid synthesis, that is forming cholic acid. So what are the functions of bile? Actually, it is for digestion and absorption of lipid and fat soluble vitamins, bilirubin and cholesterol excretion like body's primary means of elimination, and antimicrobial activities via membrane disruption, and also there's decreased absorption of enteric bile salts at distal ileum, because in the ileum only actually the bile salts get reabsorbed back, but in the case of short bowel syndrome or Crohn's disease, because of problem in the intestine, they're unable to get absorbed, and that prevents normal fat absorption and may cause bile acid diarrhea. And one more thing, actually 5% of the bile salts are excreted as bile acid resins, so that it will increase excretion. Bile salts are reabsorbed 95% at the rate terminal ileum. That is very important. Calcium, which actually normally binds to oxalate, but it binds to fat instead. So because of this, there's a free oxalate which is more, and that free oxalate is absorbed by gut, and that will lead to increased frequency of calcium oxalate kidney stones, because oxalate should be in the bound form with calcium and go away, but now oxalate is getting accumulated, and that will lead to frequency of calcium oxalate stones forming kidney stones. So bile acids are actually having taurine and glycine. They have both hydrophobic and hydrophilic ends. Okay, this is important. Now coming to another thing, actually alkaline phosphatase levels are increased more when compared with AST and ALT in the case of cholecystokinin. That is, whenever the tube, which it's coming from gallbladder and this common bile duct, the tube gets inflamed, stopped, and gets inflamed. In that case, only alkaline phosphatase will be increased more when compared with AST and ALT. But in the case of liver problem, mainly AST and ALT will be getting elevated more when compared with alkaline phosphatase. So whenever there's cholestasis, the next step you need to do is do the right upper quadrant ultrasound, so that you can find any problems related to this tree, this biliary tree. Now let us try to understand about bilirubin. Actually, the RBC, it will undergo lysis because of macrophage in the bloodstream, and it will convert into heme. And this heme is nothing but it's unconjugated or indirect bilirubin. And this, when it is attached with the albumin, and this will go into the liver. After going into the liver, before going to the liver only, this unconjugated bilirubin, in the presence of UDP glucuronase transferase, which is present in the liver, it converts the unconjugated into conjugated bilirubin, and this conjugated bilirubin, you can say, it is coming to the gut. After coming to the gut, this one will beta glucuronidase will convert this conjugated bilirubin again into unconjugated. You can see here, beta glucuronase convert again into unconjugated. But because of gut bacteria, the unconjugated will again convert into urobilinogen, which is conjugated bilirubin. This conjugated bilirubin, now it can either get reabsorbed, or it can go into the kidney and get excreted as urobilinogen, which is giving yellow color to the urine, and it can also go into the fecus, causing stercobilin, that is the brown color of the stool. So because of any of this system getting struck at any way, that will cause jaundice, that will lead to increase in bilirubin level greater than 3 is called jaundice. Okay. So one thing you need to observe is that whenever there is hemolysis, blood, there will be more heme, there will be more unconjugated bilirubin. So because of more unconjugated bilirubin, there will be more amount of urobilinogen. Okay. And in the case of biliary obstruction, so when you obstruct this condition, there will be more conjugated bilirubin, because it has already crossed the liver. More conjugated bilirubin. Because of more conjugated bilirubin, the urine will be yellow in color, but the fecus will be in clay color, because only conjugated bilirubin is increased. When unconjugated bilirubin is increased more, then the fecus will be dark color, but the urine will be clay color. Okay, so this is the thing we need to understand here.